What I will do actually, and I'm so fortunate that I will be able to present some, mostly our own research data on this. So what I will actually discuss with you today is this with single allergic morbidity, and that's actually this morning we have heard about rhinitis, we heard about eczema, we heard about asthma. When I see children with those diseases, mostly they have either asthma or rhinitis, or eczema and asthma, or all three. And you also know that multimorbidity is related to severity. So, and we have some data on this with the pollen sensitization that might be of importance when we are looking into this with allergic multimorbidity and severity. So first, what about the diseases asthma, rhinitis, and eczema, and how they develop over time? This is from then our own study. It's a birth cohort. We have been able to follow 4,000 children since 93, 94, and we have still 78% of the children in the cohort. And here you can see that over time, the overlap between the diseases increases. Blue is asthma, red is eczema, and rhinitis, we have tried to make the color looking like birch pollen. So, and here it's quite obvious also that you can see that eczema is decreasing over time, asthma is quite stable, and rhinitis is increasing. And if you just look at the proportion of children having, those single diseases, you can see that when we're talking about eczema, it peaks at around 4 years of age, 20%. And actually we have quite strict definitions. Asthma is stable, and actually nothing happens from 4 years of age. But, remember Thomas Bieber, of course, here we don't have the same patient if we are looking at 2 years of age and 12 years of age, because in younger age it's infectious diseases most likely that actually makes you get the symptoms, and later on it's allergy. And rhinitis increasing, and even with this strict definition that we have, you can see that it's more than 20% of the children at 16 years of age who have rhinitis. So what is driving this with the multimorbidity? Here you have figure 1A and figure 1B, and you can see it's a huge difference when it comes to multimorbidity. If you look at figure 1A and compared to 1B, over time from 3 years on to 20 years. This is from the German MAS study. And actually the difference is that 1B, there you don't have any parental allergy. In 1A you have parental allergy. So parental allergy is also driving multimorbidity. We also know that it's very important when we have the onset. The earlier onset, mostly the more severe development of the disease. And when we are looking at our own data, I don't know if I have any pointer here, yes, there. And if you just look at this one here, here we're looking at children where they report symptoms to birch pollen, and they also sensitize to birch pollen. And if the parents, both of the parents, are allergic to pollen and pets, you can see that already from 4 years of age, we have like 45% of the children with rhinitis to birch pollen. If the parents have pollen allergy only, they start later, but then they always reach the same magnitude as compared to the previous group. And here you have more, single allergy among the parents. So really also, this with heredity really drives onset of disease. If we are looking at sensitization and the impact of sensitization, and actually I will use sensitization as a biomarker in a very simple way. You can see that if you look at the circle here and the pies to the left, we have those children ever sensitized. Very simple. I mean, have they ever been sensitized to any allergen at 4 years or 8 years or 16 years compared to those never sensitized? And here you can see the difference among the proportion of children with eczema, asthma or rhinitis compared to those never sensitized, where you can see there's a really huge difference in the prevalence of disease over time. And if you look at multimorbidity, you can see that the overlap is much more greater in the group of ever sensitized children compared to those who have been never sensitized. So sensitization is of importance. And then here you can see that, well, if we just split, looking at children, for instance, with asthma only, or asthma irrespective of rhinitis and eczema, and if you look at the children in our both cohort 16 years of age, you can see that if they have only asthma, it's only 52% who are sensitized. But if they have asthma irrespective of any other allergic disease, 83. And the same for eczema. If they only have eczema, few are sensitized compared to if they have eczema compared to any other allergic diseases. Of course, if you have allergic rhinitis, you mostly are allergic. So to summarize this, I would say that allergic multimorbidity is driven by heredity. Heredity is of importance for early start of allergy multimorbidity, and IgE reactivity increases the risk for multimorbidity. So what is the impact on IgE levels if you are polysensitized? I mean, what is of importance here? Is it the IgE levels or is it polysensitization? And just if we look at this graph where we have used immunicap and looking at sensitization to horse, dog and cat, and this is 4 years of age, 8 years of age, and 16 years of age. Now we'll just look at the IgE levels at 16 years of age. You can easily see that if you are sensitized only to one of those three animals, you can see the IgE levels here. But if you are sensitized to two of them, suddenly the IgE levels increases. And if you're sensitized to all three, the IgE levels to each single species is very much higher. I will just bring you into this with a little bit with molecular allergology. Molecular allergology is that we don't use the whole extract anymore. I mean, we split it in the different components, different proteins that we have in the allergen source. Just to give you an example, if we look at, for instance, peanut and the peanut allergen, we have commercialized now 5 components that we can use. And then we can look at the impact of the different components in relation to development of allergy. And in our birth cohort, we had the possibility through the MEDAL consortium to analyze 795 children with this microarray assay. And then looking at grass and the grass components, again you can see that if you are sensitized to the major grass allergen component, FLEPI1, the IgE level is 1.8, compared to if you're sensitized to 3 of the Timothy grass pollen components, then suddenly the IgE levels is 35. So it really is of important that if you're polysensitized, you will also have much higher IgE levels. And on this graph, what do you think is the difference between the graph on the left and the graph on the right? What you are seeing here is the IgE levels over time to the different grass allergen components. And the difference between the left figure and the right is birch pollen sensitization. If on the left you see those who are not birch pollen sensitized, to the right you have those who are birch pollen sensitized. So again you see that really if you are polysensitized, the prevalence of other related allergens will increase. So to summarize this, that is that polysensitization to molecules of the same species or different species will lead to elevated IgE levels. And to me as a physician, I think the importance of this is that polysensitization means prolonged season of exposure. And if you have high IgE levels, we know that the likelihood will increase that you will react to those allergens. So what about birch pollen allergy and PR10s? You know, the birch pollen, major birch pollen allergen is a PR10 allergen, and within this group of PR10 allergens, we have the apple component, we have the peach component, we have the soy lime 4 component, we have the RH8 component, and so on. First, I would like to show you just that when we're looking at the levels of IgE to Birch at 4 years in relation to severity at 16 years, you can see that if you have those with moderate to severe allergy to birch pollen at 16 years of age, they actually had higher IgE levels to birch at 4 years compared to those with mild birch pollen allergy. This graph looks a little bit complicated, but actually it's not. It's here you have the number of PR10 allergen components. We have analyzed 8 or 9 in our study, and here you have that they are sensitized to the birch BT1 only, and here you have increasing numbers of positivity to other PR10s. And then you can see that the more PR10s you're sensitized to, the higher is the IgE to birch pollen, and what we just looked at was 60 years of age. So to summarize this is that when early IgE to BT1 and IgE to additional PR10s, then you have added risk of persistent birch pollen allergy. You haven't shown that. I haven't shown you that today. But early and relative high IgE to birch pollen will increase the severity of birch pollen allergy at 60 years of age. So what about cat and dog allergy? Well, here we have used the different components for cat and for dog, and you can see that if you're sensitized at 4 years of age, and we are looking at, at 8 years of age, and symptoms at 16 years of age, you can see that the more cat allergen components you're sensitized to, the higher is the likelihood that you will also have symptoms to that animal. And the same you can see for dog. Quite interestingly, when we looked at the impact of sensitization to cat and dog, and here you have that they're sensitized to cat only, to dogs only, and to cat and dog. And if you go down here and look at the respiratory symptoms, you can see that, well, if you are sensitized only to dog, only 11% report symptoms, whereas if you're sensitized to both cat and dog, 28% report symptoms to dog. And the explanation, of course, you have up here. If you're sensitized to dog only, you have very low IgE to the dog allergen components compared to if you are sensitized to both. And to summarize this part, I would state that molecular allergen polysensitization to a pet increases the risk of symptoms to that pet, and that sensitization to allergen molecules of both cat and dog increases the risk of symptoms to dog. My suggestion to this paper when we published it was that we actually should, in the headline have that, to get symptoms to dog, you have to be sensitized to cat. But the other courses like Jean, they didn't like that idea. So what do we know about peanuts? Well, again, you have almost the same slide, that the more you're sensitized, or the more number of the peanut allergen component you're sensitized to, the higher is the risk that you have a peanut allergy. And here you can see that you're sensitized to at least 4 of the 5 components. It's almost 100% risk that you will react to peanut. And when we looked at severity, we have said always that, if you the IgE levels only tells you something about the likelihood of symptoms. It never tells you anything about the likelihood of severity. But now it's the first time actually when we can see that, well, increasing levels of the very important RH2 increases the severity of symptoms to peanut. And that's particularly obvious when you look at the children of 16 years of age, that the higher IgE to RH2, the more children will have systemic reactions to peanut. And this is a paper that we have resubmitted to JCI, and of course we are hoping that it will be accepted soon. And to summarize this part, that Ige, to increasing number of peanut allergen components, seems to be a good marker for peanut allergy and predicts also peanut allergy. An increasing level to RH2 is associated to increased severity of peanut allergy. But what about the possibility to predict? Because that is, of course, very important. And to predict the persistent onset and persistency of asthma and rhinitis with the concept of monosensitization versus polysensitization. And actually, we were very fortunate not only to be able to look in our data, where we could actually, with a very special model, identify of 132 molecules that we analyzed, allergen molecules. We could identify key molecules, 18, and risk molecules for disease, only 4. And then you can see that only those 4 molecules contribute almost to the total pattern of sensitization of those children. Here you have the overall prevalence of sensitization from 4, 8 to 16 years, and you can see the increase. And with only those 4, I mean, we're almost on the same level. And then we had the possibility to replicate our data with the Manchester cohort, and you can see that here from 199 molecules, we could identify 21 key molecules, 5 risk molecules, and again, very identical, meaning that with a few molecules, we can identify the children who will develop sensitization or any sensitization. And then, of course, we were interested to see, with those risk molecules, can we predict what will happen later in life? So we use this probability curve. We have all molecules, we have the key molecules, and we have the risk molecules. And then we're looking at the incidence and the persistency of disease. You can see that with only the 4 molecules, you can see that at 4 years of age, and the disease reported at 8 or 16, but not at 4, you can see with that increasing sensitization to those 4 key molecules, the probability of rhinitis and or eczema will increase tremendously. And here you have the same curves for persistent disease. Whereas if you're using any of those 132 molecules, the curves doesn't have the same nice picture. And then when we were replicating those data with the mouse cohort data, it was very similar. And to summarize then this part is that, well, with increasing number of a handful of allergen molecules early in life, it seems that we can predict respiratory allergy until adolescence. And this is just a reminder of the major results that actually, of course, heredity drives multimorbidity, sensitization drives multimorbidity, the Ige levels are very much also associated with polysensitization, and early high Ige levels are important for severity of Birch pollen allergy. The number of components are very important in relation to onset and persistency of disease, and here you can see that we now have been able to identify some risk allergen molecules where we can identify onset and persistency of respiratory allergy. Of course, I'm not only the only guy here. We are many in the group, and lots of people to thank, and I will thank you for to listening to me today. Thank you.